good.
Dr. Bernheim completed her undergrad degree at Yale University and her medical degree at the University of California. She did her post-training in family medicine and then did a fellowship at Yale University, earning a master's degree in health sciences research and completing an additional year of research training in the section of geriatrics as a fellow in geriatric clinical epidemiology and aging-related research. Dr. Bernheim's extensive research focuses on healthcare quality, new payment policies, and healthcare disparities. Dr. Bernheim is the Director of Quality Measurement at the Yale New Haven Hospital Centers for Outcomes Research and Evaluation, otherwise known as CORE. She is the core faculty in the Robert Wood Johnson Foundation Clinical Scholars Program and as an assistant clinical professor in the section of general internal medicine at the Yale School of Medicine. At CORE, Dr. Bernheim leads work that's funded by the Centers of Medicare and Medicaid Studies to develop the next generation of performance measures across multiple care settings. Dr. Bernheim is going to discuss value-based care and the work of Centers for Medicaid and Medicare Innovation. Dr. Bernheim, thank you so much for being here. We welcome you, and we're very excited to learn from you.
Thanks. So I will give you a slight update to that excellent intro. Thank you very much, Chris, which is I worked for many years as Yale faculty and, well, partly as hospital and partly as Yale faculty, but as a senior director of work at the Yale Center for Outcomes Research and Evaluation. But about 16 months ago, I made a transition and I'm now serving as the Chief Quality Officer and Acting Chief Medical Officer at the CMS Innovation Center. So part of why I'm here today is that role at CMMI. And previously, I think this cohort spoke to Dora Hughes, who had been the prior Chief Medical Officer at the CMS Innovation Center. So everything Chris said is true. There's just more to add on top of it. I spent a long time in the world of developing performance measures and working closely with CMS, and then again made this transition over to CMS recently. Other things I should know about the background, can we start with introductions? But I don't know, Chris and Marvin, is there other ways you want to approach launching this?
I suppose people could go.
Go ahead. I was just going to say we've had several speakers. If you would prefer, we obviously could introduce ourselves in turn, or if you just want to jump in, whatever you prefer, ma'am.
So I would love to know who I'm talking with, and I'll tell you what I set up, and I hope is going to work for all of you. Is I have a very small slide deck that talks about the Innovation Center, just to sort of set the groundwork for a discussion around value-based care, and particularly what we're doing at the CMS Innovation Center. And then really left a lot of room for a discussion to the extent that you all want to talk about my past work, what the Innovation Center is thinking about, career paths, whatever it is. I'm really open to being helpful to all of you. But I'd love to know who I'm talking to. So do you guys have a system for pinging each other, or should I just say the names I see on my screen? Great, thank you all for the introductions. It's really nice to know. So many of you are rising second-year med students, but not everyone. And this conversation is coming midway through a course that you've had other speakers for. So I'm curious how much conversation you've had about value-based care already, or around alternative payment models, just so I know our starting place.
I'd like to answer that. I'm Marvin Malik. I'm the curriculum director for this internship, and we're only in our second week, and we've only had really the briefest introduction. We talked about the structure of the Medicare Advantage system, but most of the work you're doing, I think, applies to people who elected not to go into a Medicare Advantage plan. So we really haven't gotten very far. So I think if you describe what kinds of models you're working on, that would be great. And I think you can assume we don't have a whole lot of background there yet. And you're here for the star of the show on that topic.
Great. Okay. Then actually, before I even bring up the slide deck, I will just say a couple of fundamental things about sort of I think the concept behind the Innovation Center and the kind of work we're trying to do, and then I'll walk you through the slides. Although some of these I think actually are, I think I actually do this in the beginning of the slides. I take it back. I'm going to go ahead and bring up the slides, and I'll just take my time on them. And please interrupt me to ask questions. You know, I'm here to help enrich your internship, so I'm happy to take time to answer questions. And I only have a small set of slides to present, so there's plenty of time. Let me see if I can share. Are you all seeing a slide deck that says Introduction to the Center for Medicare and Medicaid Innovation?
Yes.
Great. Perfect. Amazing. Okay, so this is me. Just to say one more word about me. So I am, as you said, a family physician. I still do a little bit of clinical work, and then did additional training at Yale in health services research, what was a fellowship funded by the Robert Wood Johnson Foundation previously, called the Clinical Scholars Program, but now continues to exist as the National Clinician Scholars Program. It is a 2-year postdoctoral fellowship for both physicians, including DOs, and PhD nurses, and it is research and policy focused, and really great training for moving into health policy work. And as we mentioned, spent some years as faculty of that program as well as doing work there. So the Innovation Center, which is sometimes referred to as CMMI, but we tend to call it the CMS Innovation Center, was a new center as part of the Centers for Medicare and Medicaid that was created by the Affordable Care Act. So that's a starting point, that the Centers for Medicare and Medicaid Services are the federal home for traditional or fee-for-service Medicare, for the federal oversight of the Medicare Advantage plans, and for the federal component of the Medicaid program. But when the Affordable Care Act was passed in 2010, there was a desire to be able to test different ways of paying for healthcare to see if we could both improve quality and reduce costs. And so the Innovation Center, CMS Innovation Center, was created as part of the Affordable Care Act with 10 years of funding that automatically renewed. So we recently started the second decade of the Innovation Center's work at CMS. And really, at a very high level, the idea behind the Innovation Center is to test innovative payment and service delivery models. And I'll talk about what that looks like to reduce program expenditures and either preserve or enhance the quality of care. I think Marvin, you mentioned, and it's true, most of our work historically focused on Medicare fee-for-service beneficiaries, but our statutory authority covers Medicare, Medicaid, and CHIP. So we have recently, and I'll talk about this a little bit more, really started to expand into thinking about alternative payment models in the context of Medicaid, which presents some really important opportunities and challenges. One more just big picture slide on the Innovation Center. So literally what the law says is that the purpose of the center is to test innovative payment and service delivery models while preserving or enhancing the quality of care furnished to individuals. And there's 3 ways that the models that we build and test can be considered to be successful. One is if they improve quality and do not increase spending. Another is that if they don't harm quality, but reduce spending. And obviously the best case is that they both improve quality and reduce spending. And the way that the statute is written means that if we build an alternative payment model and it's shown to do one of these 3 things and meets other prerequisites, it can be expanded. So the idea is to have a space within Medicare where we test new ways of paying for healthcare. And if we're successful, it can then expand into other parts of Medicare. And really that hadn't been done before. And I think the 2 most important components are both what are we trying to change in healthcare payment within the Innovation Center, and to my mind, part of what's really exciting about the Innovation Center is it's one of the few places where we test changes before we do them broadly, right? I mean, normally, if we change a rule about how physicians are paid, the Centers for Medicare and Medicaid Services puts a regulation out and just makes a change and it applies to everyone. But the Innovation Center was really created to do these tests and to do a thorough evaluation of the tests with pretty strict criteria for how something can be expanded. So it created a neat opportunity to try to change how we pay for healthcare in a thoughtful way. Before I move to the next slide, I'm just going to say again, starting from scratch, because people throw around different terms, and again, I want to set a level playing ground. We often talk about value-based care as sort of the basis for the work we're doing. And forgive me if this is elementary to you, but I think it's useful. You know, traditionally in Medicare and most payments, clinicians are paid for the things that they do, a procedure or a visit. And the concern is that the incentive embedded in that is to do more. Now, there are plenty of places in the US healthcare system where we underuse care. So it's not that we're all about overuse, but the system isn't set up to reward clinicians for being efficient or to reward clinicians for doing a good job, to respect their patients' wishes, get the outcomes that are most important to their patients, use evidence-based care. So fundamentally, the concept behind value-based care is to shift the incentives so that we are shifting payment so that it's more focused on the things that matter to patients and addresses any incentives for overuse. Now, when I went to medical school compared to where you guys went to medical school, this was a more novel idea. I actually suspect, even though Marvin said you guys haven't had a lot of introduction to this, because value-based care has changed the healthcare market so much in the last decade and a little, that this is actually familiar to you. And you may have heard of some of these terms. You may have heard people complaining about quality measures or about the MIPS program or the macro reform or prospective payment. So lots of this may actually be in your world as you're doing your clinical training. But when the Innovation Center was started 10 years ago, these were much more novel concepts. It was much less common to try to base payment on a combination of cost and quality and really incentivize reducing costs and improving quality. So what the Innovation Center does is develop alternative payment models. The idea is that we have part of what the law gave us was the authority to be able to waive some of the traditional rules so that we can test new ways, traditional rules of payment in healthcare, so we can test new ways of paying for healthcare. But the models, the alternative payment models tend to contain many aspects beyond just changing the payment rules. And they happen in all different spaces over so we're now, as I said, starting the second decade of this work at the Innovation Center. So I'm just going to, this next slide talks about what do we mean by innovation, and just checking the slides are still progressing fine. You're seeing one now that says defining. Okay, perfect. Again, we refer to these payment and delivery system models as alternative payment models. And exactly as I said, they're meant to reward high quality, cost-efficient care, but they can be in lots of different spaces. So we have some alternative payment models that really focus on a condition or a diagnosis. We have a number of models we've tested and are continuing to test that look at patients who have renal disease. Sometimes we look at a kind of defined episode of care, like a joint replacement. We've had a model that was longstanding that looked at many different episodes of care. All of them started with a hospitalization for a certain time period and looked at cost and quality over, say, a 90-day period from when that hospitalization can start, and tried to incentivize for that episode of related care. Could we improve quality and lower costs? Some of them are more defined by the kind of provider that we're incentivizing or changing care and quality for, like primary care providers. And I'll give you examples of these specifically. I'm just trying to give you the global picture of the different ways that we can orient our models. Some of them are more focused on trying to bring innovation to distinct areas, like rural areas. A number of you are in states where we are thinking a lot about the issues of rural healthcare, which, again, if you haven't seen it yet in your training, you will. Is very challenging, very hard for us to really make sure that there's a right access for folks who live far from healthcare facilities. And sometimes we look inside, and this is relevant to Marvin's other point. We had focused early in the centers on primarily traditional Medicare payment, fee-for-service payment, but we also now do think about Medicaid and Medicare Advantage. What we aren't doing, and I think it's useful, is that we're not a testing center for sort of late-breaking technology solution. Now, sometimes our models create environments in which clinicians decide to test new ways of providing care, and they may bring technology solutions in if they are a clinician who is participating in one of these models. But that's not our function. Our function is not really primarily as kind of a testing center. What we're testing is new ways of paying for healthcare, but we wrap a lot of other things around that when we design the models. I'm gonna, before I go to the next slide, talk a little bit about what a model looks like, because I think it's just, for me, helpful to get your head around it, but I wanna pause and see if people have either questions or clarifications, or if I'm going way too slow, tell me to move faster. Okay, I can only see a few of you, but I appreciate the head nods. It helps me to know. Anybody have questions? Okay, so I'm going to give you examples of a couple of our models, because I just think it makes it much more concrete to sort of imagine yourself as a clinician and sort of what's changing in your life, or imagine yourself as a patient and what's changing in your life. The other thing I'll say that's not listed here, but is probably the most commonly known version of an alternative payment model, is an accountable care organization, or an ACO. This is a concept that's been adopted a lot by private insurance as well. And there is one place in Medicare where there are ACOs that are not part of our innovation center, that are actually already embedded in traditional Medicare, which is called the Shared Savings Program. So I'm going to talk a little bit about sort of how an ACO is structured, and then I'll give an example from one of these other more specific ones. So the concept behind an ACO is that there is an organization that is taking accountability, and this is a really important word in our world, for a set of patients. ACOs can be structured in many different ways. So it's not necessarily a hospital, it's not necessarily a group of physicians, it's often a hospital in association with a group of physicians. Sometimes it's an external organization that brings providers together to run the ACO. But there are rules, or they're set up ways in which it's determined kind of who those patients are that you're accountable for. And usually for ACOs, that's based on where patients are seeing their primary care physician. Sometimes patients have a choice to say, you know, Gabriella is my primary care physician, but most commonly what we're doing is looking at the history of their Medicare claims and saying, it looks like over the last 2 years, this has been the person who's been most responsible for your claim. And we have complicated algorithms that say that. But if you enter into the program as an ACO, whatever, again, combination of sort of clinicians, hospitals, healthcare organizations are doing this, are saying the patients whose claims tell us they are our patients, we're now going to be, and my phone is making a lot of beeping, we're now going to take accountability for the cost and quality of their care. So it's a slightly different structure, just even for sort of who your patients are. Now, pivoting for a second, if we're talking about a renal model, the way we decide who your patients are is very different, right? Then it's more about who they're getting their renal care from. Or if we're talking about an episode-based model, it starts with the hospital where you had your surgery. So it's not always based on your primary care, but in the context of the ACO, we're essentially trying to determine, usually through claims, but sometimes through patients declaring it, who is your primary care provider. And that group of patients then becomes the group that the ACO is taking accountability for. The way that we figure out if we're successful is we use historical information to understand for that group of patients based on how old they are, what diagnoses they have, other factors, sometimes some of their health-related social needs. That's a side note we can talk about if we want to. We essentially predict what would it normally cost Medicare to take care of this group of patients over the next year. And the ACO, then we track essentially how much it costs to take care of those patients. And if there's a gap, which is considered the shared savings, so normally it would have been $100,000 and instead it was, you know, $1,000 less than that. If there's a gap, the concept is that that savings is shared between Medicare and the provider group, whatever that ACO structure is, so that we are creating through that sharing of savings an incentive to reduce what would be anticipated costs for this group of patients. But quality is also really important, and I am the chief quality officer, so I think much more about not how we build those financial models to predict what the costs would have been, but instead the quality piece. And the different alternative payment models can be structured differently, but they all have some link to quality. And the way that works essentially in the ACO program is that there are quality thresholds, there are quality measures. You're judged for that set of patients, how you've done on quality. And if you do well, you have it either lets you have access to that shared savings or more of that shared savings comes back to you. If you do less well on quality, then you have a reduced access to it. So your quality scores impact the extent to which you as an organization can make money during this. Can you hold on for just 1 second? I will be right back. Hold on. Wait. I apologize. We have a new puppy in my house, which means that you have to know at all times who's got the puppy. Okay, so I'm going to pause there. But the ACO model is not the only model, but I just wanted to give you a feel, like, what does it mean? So if you didn't have this model, you would be seeing the patients you see. You wouldn't necessarily have that sense of accountability for this set, and you wouldn't be incentivized in nearly the same way to both decrease cost and improve quality. Now, there are ways that we incentivize improved quality outside of these value-based payment or alternative payment models, but they're more closely linked to a set of patients that you're really accountable for. There are a million details, some of which I could explain and some of which I really can't, about how we actually do all the financial accounting and the ways in which the quality measures are tied to payment, and they can be different in different models. But in a simplest form, that's kind of the concept of what we're trying to do with these models. As we go on, I'm going to give examples of many more, but I just wanted to sort of give you the feel for what we're trying to do and sort of what value-based care can look like. I'm going to pause again to see if folks have questions.
I actually have a question.
Sure, great.
So I was reading about some of your models on your website, and I was just kind of curious about how you come up with them. Are they primarily research-based? Do they come from previous studies that have been done, or is it just kind of we've noticed this discrepancy, let's see what we can do about it?
That's a great question, and it's really a mix. What I will say is it takes a very long time to develop a model, so there's a lot of inputs when we build a model. I think that I'll say a couple of things. I think that in the early years of the Innovation Center, cost reduction was really a stronger focus, whereas under our current leadership and our recent strategy, we're really trying to emphasize both the improvement for the benefit of patients and the cost side of things. And so some of the earlier models, I think, focused particularly on places where there was evidence that there was a lot of overuse. And some of the places where we've had success, for instance, are in the post-acute care, right? The amount of time and money spent when patients leave a hospital being in skilled nursing facilities or long-term care or whatever else. So that's been one of the places that had been a focus in some of them. But there's really a lot of inputs into the concept for a model, research for sure. We talk to a lot of stakeholders. We have both beneficiaries and patient groups that we talk to, or advocates for those, and providers. We look at what's happening in the industry. And then internally, the process is that we develop a sort of an initial concept, goes through some approval, we build it out further, but then ultimately, before we can put a model forth, it has to be cleared throughout HHS. So there's a lot of other components as well. Although we build and design the models in the CMS Innovation Center, but before they get announced as an alternative payment model, they're also getting cleared by HHS and OMB and the White House. So there's a lot of inputs along the way. And folks are looking to make sure that the investment we're going to make in building one of these models is going to, is likely to both reduce costs and be meaningfully improving things for patients. Gabrielle, I see your hand up. I won't always see hands, so don't hesitate to jump, but it seems to be telling me when hands are raised. So please go ahead.
Perfect. Obviously there's a lot of steps that you just covered in your response to Kaya's question. I was wondering what the typical turnaround time is between going through all these testings, and then like the training process for making sure physicians and staff and all that understand the model. And yeah, thank you.
Yeah, it's a great question. And what I'm going to do is I'm going to give you a quick answer, and I'm going to go through a little bit of the next slides because I'm going to talk a little bit about how things have changed at the Innovation Center and what we've learned over the last 10 years, and it gets to that as well. So the time between when we start talking about an idea and we actually announce it varies enormously, right? Because sometimes we put things on the shelf and we come back to them. Sometimes they take longer to go through clearance. So that's a variable. I mean, I think it probably is a minimum of a year, but often 18 months to 2 years to really sort of develop the idea. But from the time we announce a model, a couple of things happen. One is, the first thing is that we announce, and you can see this on the CMS Innovation Center website, that we say like, here's a new model, but then we have to put out further information that's really detailed so people can decide if they want to apply. So just last week, I'll just give you an example. We had announced last winter, I don't remember the exact date, a model that's focused on behavioral health. It's called Integrating Behavioral Health, and it's actually one that's focused on Medicaid. So the participating providers are actually going to be Medicaid state agencies. We just last week put out the notice of funding, which then says in much more detail, if you would like to apply, state Medicaid agencies, to be a part of this model, here's what the application looks like, here's what's being expected of you. It's sort of it's like a release notification for a grant or something else. These aren't grants, but you know what I'm saying. It's a notice of a funding opportunity. They then have some time to apply, and then there's some time before the model launches. So there's, you know, some number of months between when we say we're putting out a model, when we tell you exactly what it takes to apply, when we review applications, decide, and then it starts. But I think you're actually asking a slightly different question, and this is something that's changed, which is one of the things that we've learned is that, you know, what we're ultimately trying to do is transform how care is delivered, right? To really refocus, and that can take a lot of time. And so in some of our more recent models, which is very different than, well, it's different than previous models, we've actually built in some pre-implementation time so that when a model launches, often the providers who are participating are not yet on the hook for some of the cost and quality pieces. They're more in a phase of investing in infrastructure. We're often providing some support. We have an entire group within our center that's called the Learning and Diffusion Group, and that group supports providers. The model team that also has a contractor that helps support providers. So we now sometimes have up to 3 years once the model starts before it goes into place. It's not usually 3 years. That's a pretty, but we recently proposed a new episode-based model that would be for hospitals looking at 5 different surgical conditions and tracking cost and quality for the next 30 days. And we proposed that hospitals would have a year before any dollars of theirs were on the line for this model. And safety net hospitals, I believe, don't quote me on this, I believe we proposed that they might have more time. I can't remember if it's 2 or 3, but you know, acknowledging that hospitals that may have fewer resources might need even more time before they're at risk for dollars around savings. So that's something that has changed because we want this to lead to sustainable transformation in how care is delivered.
I have a question
Okay,
sort of building off of that.
Oh yeah, please. Great.
I'm curious if there's like a notification process for any patients who are like visiting these hospitals that are trying to implement an alternative payment model. Like, how do people know that this is happening?
Yes, there is. People are informed, and it's something I've actually recently heard from patient advocates. They'd like even more. One of the things we've been working on as a center is trying to tell the story of what we're trying to do to beneficiaries, because it's really focused on trying to make things better for them. But sometimes people think the word value means sort of getting less. You know, there's a lot of there's a lot of feelings about the word value-based care. And so we have a really terrific communications group, and we've actually done a fair amount of work recently on our website aiming to have patient-focused materials on what value-based care is and telling some stories and how it has, because ultimately, it should be freeing providers to provide more coordinated care that is something that patients really want. So yes, folks are informed, and we're trying to just also tell the story of this work with patients at the center of it, because I think that's really important. I'm going to share a couple more slides, but I'm happy to pause for questions again anytime. So as I mentioned, we're in the second decade of the Innovation Center. There were many successes in the first decade, but lots of lessons learned. And Liz Fowler is our current center director. And when she came in, she took some time to really look at what some of the lessons learned were and changed our strategy a little bit. So I'm going to just talk a tiny bit about that. This is a slide that talks about some of the lessons learned looking back at the first 10 years. One is that in the original 10 years, we did some work to say, how much are safety net providers coming into this model, which means patients who go to safety net providers have the opportunity to get exposed to value-based care. How much are our models influencing health disparities in different ways? And really had not been a big focus of the first 10 years. So that was one of the things that Liz was paying attention to as a strategy refresh. We had put out a lot of models in the first 10 years, and sometimes that was confusing to folks. There's a big piece of our work that is, let's say, has a lot of trade-offs, which is whether or not models should be voluntary or mandatory. So we do have the authority to say this is a mandatory model. And then I just mentioned that we've proposed in this year's hospital regulation to have a mandatory model looking at surgical episodes of care. What that would mean is that we would select a set of areas in the country, and the hospitals that are in those areas, for those surgical episodes, they would be on the hook for our cost and quality setup, not by choice. That is, as you can imagine, controversial. People want to choose to enter these models. So historically, we've mostly done voluntary models. The problem with voluntary models is that it's harder to do a clean test and really understand, because people can come in and out of them if they don't like what's happening. So it's much harder to accrue savings in voluntary models, and it's a little bit harder to be sure what the impact of the model has been. And there's been different leadership at different times, more or less supportive of whether we do more voluntary or mandatory models. There's a piece that I didn't talk about when I talked about the structure of these, but it has to do with this concept of downside risk, right? So when I talked about shared savings, essentially the idea was if you achieve savings and do well in quality, you get a little bit more money. But some models are set up where if you don't do well, you lose a little bit of money. That's downside risk, right? So some of them are designed as only upside, and some are described as downside. The providers often have even more flexibility and ability to change things in downside risk, but they're also taking on more risk. And that was one of the things that was noticed looking back in the models, that we hadn't had as many providers willing to take on downside risk. Some of these get a little bit weedy, but as I mentioned, right, in order to determine if there's savings, we have to set benchmarks. We have to give people benchmarks, and that's often based on historical data. It's very hard to do, right? I mean, you can imagine COVID comes along, your predictions about how much patients are going to cost really changes, but many other things can disrupt that. So that's just been a challenging piece of this work. I'm going to come back to the success of models too narrowly defined, because that's a piece that I think about a lot. And then, part of what Liz really brought was trying to bring in the focus on patients and beneficiaries. So what came out of this looking back at 10 years in 2021, which now is a while ago, but when I joined the center, it seemed like it was very fresh, was this concept of a strategy refresh for the center. Again, based on the same authority, still trying to design alternative payment models that reduce spending and improve quality, but changing our emphasis a little bit. I don't know whether you can read the small print in this slide, well, but the concept is that we're really trying to drive towards a health system that achieves equitable outcomes through high quality, affordable, and person-centered care. So you see some of the emphasis on things like affordable and person-centered, which were a shift in the focus. The first of these focus areas are, and can you see my cursor when I'm swinging it around? Because I've been swinging it around randomly. Okay, sorry, I wasn't paying much attention to that. I should pay a little more attention, but I will. But I think it's helpful on this one. The first of the objectives were around driving accountable care. So accountable care is this concept that you as a patient have somebody who over a longitudinal time feels accountable for your care and is thinking about both cost and quality, is trying to improve cost and quality and sort of these as our patients. So some of our models meet this definition, not all of them do. Sometimes we're testing things that don't fully meet this definition, but we're really, a strong focus of the center is getting to the point where all Medicare beneficiaries are in an accountable relationship where somebody is seen really as their main provider and is watching out for cost and quality. On the advancing health equity domain, the focus here has been thinking about models that affect different populations. A lot of this has been bringing in Medicaid providers or other safety net providers. It's been making sure that we have good data to understand the impact on health equity, so we've done some data collection. And often it's been changing some of those financial benchmarks in order to account for the fact that hospitals that may serve more underserved populations may need more funding. Their benchmarks maybe should be a little bit different. So we're often adjusting benchmarks to address the ability of safety net providers to innovate. Supporting innovation is everything we do. One of the things we focus on here also is, as I mentioned, our learning system, but also, I think I have a whole set of slides that go through these. You know, wait 1 second, sorry, I forgot. Okay, so I said this already, people in a care relationship with accountability for cost and care, embedding health equity. This support indication, as it says here, is a whole range of supports around how we provide learning and data to really help this transformation. So we're not just putting forth new rules about payment, but we're really doing a lot of work to support the transformation of care by the providers participating in our models. And also embedded in this is a piece that I'm focused on, which is including in our measurement of how we're doing on quality, more measures that use the patient's voice that are patient-reported measures. I'm realizing the time is going by quickly, so I'm going to actually move through these a little faster so we can make sure to leave a little more time at the end for questions. But the last two are affordability. So another important piece is that even if we're reducing health spending, that doesn't always mean it's easier for beneficiaries. So also paying attention to things that are causing waste in the system or literally causing costs for beneficiaries. And then this last one is about partnership, that there's just a lot of what we're doing is with states. Sometimes we're trying to align with other payers, things like that. So that was our big strategy refresh. I'm not going to go through this in detail because I feel like it probably is not the focus, but just to give you a sense of how we're organized, we have 3 groups with the Innovation Center that focus on developing the models. They are called the Patient Care Models Group. They focus mostly on primary care and some of these advanced bundled payments or specialty care models. We have one, for instance, for oncology now. The Seamless Care Model Group has 2 pieces. One is more of our ACO work and some work we're doing with Medicare Advantage and prescription drugs, which is a very different type of model. And the State and Population Health Group has done some statewide models. Somebody said they're at UVM. Vermont has a CMMI model for the state as a whole, partnering with a statewide ACO. That was a unique experiment in Vermont. Maryland is another state that has a statewide model, and we have accepted applications for future versions of statewide models as well. But we also do some Medicaid-specific models, like the one I mentioned about behavioral health in this group. And then we have a whole set of groups that are sort of cross-cutting. I'll just be really quick here to say there's a group that's all focused on the evaluation. Every model gets evaluated. There's a policy and program group. That's actually where my work sits, but lots of work is sort of cost-cutting. And there's this learning and diffusion group, which I think is a really important feature of our work, which is that the learning and diffusion group is really supporting participants with the changes they're trying to make. And then just to give you a feel for how many different value-based care models have been out there, the ones that are in black have been completed, and a number of different things happen when a model ends. But the ones that are in blue as of when this slide was done, so it's a little bit close, are either active, announced, or things that we are working on. So it's a big portfolio, and they're all over the place, right? So just to give you a feel for our impact, there are 7 million people in Medicare who have received care through one of our models, and more in Medicaid. The last slide I want to show, and then I want to just make space for questions, is just kind of rather than that crazy long list of all our models, a little bit of a sense of sort of how we're rolling things out over these last bunch of years. Because I think, again, just giving you a sense of like, what are we doing, what's happening? So the models that we announced last year, so we had a strategy refresh that focused on all of those areas, and then we took a little time to build new models with that strategy in mind. And in the last year, and this 2023 and 2024, many of those newer models have been announced. So these are the most recent models that we've been announced. And actually July 1st, a few of them are launching. So one is called Making Care Primary. This is obviously a primary care focused model. This model really focused on bringing providers who had no experience with value-based care into value-based care. It has a tiered way of bringing providers along. It focuses on bringing federally qualified health centers in. It's only in 8 states. There's only 8 states where people were allowed to apply for it. It's about to launch. We have a model that's really focused on dementia care. This is a model that's part of the focus is allowing for payment for respite care for caregivers and making sure that there's a lot of access and training and planning for caregivers. Part of the goal here is if we can take better care of caregivers, we can take better care of patients with dementia, and they're more likely to be able to stay out of long-term nursing facilities, and that's where we would achieve the savings. It's really focused on improving quality, but also the thought that if we delay long-term nursing care, we'll have some savings. The AHEAD model, States Advancing All-Payer Health Equity, is a statewide model. That one we haven't announced who's going to participate, but is a big statewide model where states agree to have some of their hospitals have global budgets where they actually are sort of have a budget for the hospital in a very different way of addressing costs, and has a strong equity and primary care focus. Transforming Maternal Health is a Medicaid model that is focused on improving maternal health. It has focus on things like creating more availability of doulas, creating the infrastructure for better data. And because it's Medicaid and this is hard work, this is another one that has a long pre-implementation. States are going to have some time before they have cost and quality on it. And then this year, I mentioned the behavioral health one, cell and gene therapy as a drug model. We also announced within the existing shared savings program, a primary care focused model to try and invest more in primary care inside of these ACOs. That's called ACO PC Flex. It's not listed here, but it's meant to be, it's represented by this one. And then we're thinking about new models for the future. Anyway, it just gives you a sense of sort of how we're thinking about our roadmap going forward. And that's really the end of my slide deck. I have a slide of additional information if you want to look at our website, email us questions, follow us. But really, that's the end of the presentation itself. And